Okay, well, let's go ahead and get started. Thank you all for joining us today. Again, I'm Rebecca Robinson. I'm the Administrative Director for the California Perinatal Quality Care Collaborative, CPQCC, and I am delighted to be here today. I've been with CPQCC about 7 years now. No, 6 years. Seems like forever, and no time at all. So I've been really honored to work with the wonderful community around the NICU and to watch as our work maintains its focus on the care and outcomes for NICU infants in the NICU, but also expanding our focus to really include health equity and trying to lessen the disparities of care and disparities of outcome for families and babies in the NICU. And I have just been so privileged to be a part of that. And I also want to introduce Ashley Randolph, who is the founder and president of Glow Preemies, and also the co-chair of the Within the NICU Health Equity Subcommittee at CPQCC. Now I'm going to jump back, just for a second to talk about where we are. The Within the NICU Health Equity Subcommittee has come up with a wonderful mini toolkit of information on how to support families with a non-English language of preference. And so today we're talking about some of the logistics of how working with those families goes. So I am going to, and I think we've had one or two more people join us. If you don't mind putting in the chat where you're from, that would be great. So I am going to move on to this slide and turn it over to Ashley.
Thank you, Rebecca, and welcome again, everyone, for being here today. Thank you for being here, I should say, for being here today. Before I get started, I will echo what Rebecca said. We're very happy for all of you being here, especially to talk about language in the NICU. I have a pleasure of working with Rebecca. She's been here for 6 years. I believe I've been here for 5. So it has been a wonderful joy to work with her and to at least meet all of you. So to get started today on this wonderful topic, many of you have attended, and I apologize, I did lose my voice this week. Many of you may have attended the January webinar when we released this bundle of resources to improve care for NICU families with a non-English language of preference. The recording and slides are linked here as well, and I would love for you to see the new QR code that we have here, where you can easily download the NELP bundle flyer. The toolkit is also available on our website. Next slide. Okay, now this is a screenshot of our beautiful mini toolkit. We wanted to give you very action-oriented recommendations. These were developed by the Within the NICU Health Equity Committee, which included physicians, nurses, NICU parents, interpreters, social workers, and others who were so passionate about reducing this disparity. Everything that we created were evidence-based or evidence-derived. And in this toolkit, we will link to other printable resources for staff and family. This is also a reminder that you can find this on the CPQCC's website or the QR code that was on the slide before. Next slide. And I will pass it back to Rebecca.
Thank you. Now, this is where we really do want to start the discussion. This isn't a webinar so much as it is a two-way conversation with you all. We want to give you some ideas that were brought up in the toolkit, some potentially better practices, as we call them now, but we also very much want to hear from you and want to hear how things are done in your NICU, in your hospital. So some of the change ideas that were brought up that are brought up and brought out in the toolkit is seeking, let's start with the first one, seek qualified bilingual staff. So this isn't necessary, this isn't a certified healthcare interpreter. This is staff that have been appropriately assessed and found to possess the appropriate skills in a language other than English. Obviously, there's you can be quite fluent in another language, but maybe not know the medical terminology, and maybe not have quite the grasp of the terminology and the technology that you would need in order to be able to pass healthcare information along to parents. So so let me just go through this. They're different from the interpreters, as they can only use their language skills in direct conversations with the families. They can't interpret for other providers on the team. So they can provide language concordant care, which is tied to higher levels of patient family satisfaction and may reduce the time patient family interactions require. So qualified bilingual staff, it sounds like, are people who don't need interpreters themselves to be able to communicate with the families, but they cannot work as interpreters. They cannot serve as an interpreter for another provider on the team. So in order to bring that skill set onto your team, you need to incentivize and reward those staff, of course, hopefully providing financial compensation to staff that have that qualification. And this says click here, of course, on the slide. That's not terribly useful, but in the toolkit, that is a live link that goes to more information. So I'd like to open it up to the group and ask you, each of you, is this something that you do at your site? Do you have qualified bilingual staff? Do you have do you have this in an official or an unofficial way? And if you'd like to raise your hand or indicate that you want to speak out, that would be great. So any thoughts on that? Is that something that you might want to? Yes, Julianne. Thank you.
Hello.
Hi.
Hear me? Yes. At Natividad, we once upon a time had qualified bilingual staff, and the difficulty was I would happen to be one of them, and they took my qualifications away because here in this hospital, according to the county regulations, any qualified bilingual staff could be called to serve in another area. So maybe it would take me away from the tasks that I would have particularly. So I have a certain role. I'm a supervisor of the chaplains, and I'm also on the palliative care team and spiritual care team. And I also work with the trauma team. And so it became too complicated for them to just pull me away at any moment because I was a qualified bilingual staff. So they kind of took that designation away, and now they use interpreters almost exclusively.
Thank you for sharing that. Have you found that has impacted what's the impact been of that on care, do you think?
Well, personally, I think it hampers the care because we need to wait for interpreters very often. Sometimes I can do the translating and the interpreting, but we have to wait for someone who's in that role. And so it takes time away from the care, it takes time away from the communication that could happen. It just consumes way too much time. And then also not every case interpreters are available. So that's another drawback.
Right. Right. Interpreter availability is a really big issue, it sounds like. So it sounds like it was when they were using qualified bilingual staff, those staff could be called away at any time. So that could be disruptive to your work. But you didn't have to wait for interpreters when you had the opportunity to act within your own sphere.
Right.
Yeah.
Exactly.
Okay, thank you. Kim, I see you have your hand up.
Hello, this is Kim at Watsonville Community. So interestingly, we have staff that are designated qualified interpreters, right? So they have many of them have a badge that shows that they're an interpreter. And I think they do get, a modest, very small financial incentive. But the interesting thing that I heard you saying is they're not really supposed to translate for other providers. And to be honest, they translate for each other, and sometimes they'll translate for the physicians. These are nurses on our floor, right? So they know the lingo, they know the discussion, etc. But that's how it's working here. Now, mind you, not everybody. And we also have folks that are, say, Spanish speaking that will interpret for another nurse who's non-Spanish speaking. That's not an actual qualified bilingual person officially, right?
Right.
And then beyond that, we use the CIRCOM Proprio and Indigenous language line for other translations when we don't have someone who can, have the language skills for that particular language, particularly Mixteco.
Great, thank you. So it sounds like you do have the sort of the qualified bilingual staff, but they are doing more than this is saying. They are interpreting for other providers. It just feels like around language, so many things, we want to put rules in so that things are handled appropriately, but at the same time, sometimes you need more flexibility than is really defined. I mean, to say, well, we don't want you to interpret for a fellow provider in case, you don't have the full training you need. And it's like, this person's standing right here. I know I can interpret what they're saying properly.
Yes.
Of course I want to do it. Yeah.
Yeah, exactly. And availability of those translators, as previously mentioned, is a very big issue, and which is why we have more than one service to try to make sure we have coverage.
Right. Thank you.
Yeah.
Thank you for that. Yes, I'm sorry, I'm calling you Julianne because that's the name that's on the screen, but I realize it's not just Julianne who is there. Thank you. From Natividad, you have your hand up again. Thank you.
I wanted to just introduce George, who is the lead for interpreter services at our institution. He just came in and I wanted to introduce him to you all. And I think he had kind of some thoughts as well related to your slide.
So I was just curious, I kind of read the verbiage now, so it's actually very similar to our program here, but I'm curious in regards to these qualified bilingual staff, have you seen if there's been perhaps an uptick in regards to them being pulled or utilized for interpretation, even though that's not exactly what it means? And if so, how do their skills compare to that?
That's a great question and welcome. Thank you for joining us. This is great.
Yes.
I'd like to put that out to, well, I'd like to ask Ashley if she'd like to comment and put it out to the group.
Okay, so I think your question is, and let me know if I'm wrong. I think you asked, do I see qualified interpreters and regular interpreters working together? Can you repeat the question for me?
Sure, yeah, it's just because I'm seeing that you one of the components here is that you have qualified bilingual staff. According to the verbiage, which is very spot on to what we do, they're qualified to speak of their own volition to patients or to other individuals in the hospital, but not exactly to interpret. But
yes,
from time to time, because of situations or even just lack of knowledge, they're pulled because they speak that language and they're put to interpret, and they may do so. So I'm just curious, do you see that there's an uptick in using these individuals as interpreters, even though that's not what the designation is?
Yes.
And if so, how does it compare to an actual interpreter in regards to skill set and quality, I guess?
So when we were making this toolkit, we did have a lot, and thank you for that question and for being here, first of all. We did have a lot of people talk about this in our discussions, making the toolkit. And some doctors that were a part of this, and I apologize, I lost my voice earlier this week. There were some doctors who mentioned that the information wouldn't be accurate because they didn't know the right terminology to use in that language. And so for them, that was the biggest area of concern was, if they're trying to tell them about a surgery and then they hear it and it's either not specific enough or, they're not going into detail enough or they're missing something that will later affect the family, that made a big risk. And so that's why we made this toolkit, because at first we realized that people were either turning to iPads or they weren't using anyone at all or relying on a family member to tell the individual what was going on. So a qualified bilingual staff member can help, but I don't think that it will completely fix what an interpreter can do, if that helps answer any of your questions.
Yeah, thank you.
You're welcome.
Emily.
Hi, yes. So here at Loma Linda, we have several bilingual staff members. I'm thinking of physicians specifically. I don't think any of them are officially qualified to be bilingual providers, meaning they haven't taken an official test. We have very, very many Spanish-speaking nurses, and we have a very high demand for Spanish interpretation. I think there's just an overall lack of education regarding what it means to be a qualified bilingual staff member. And like you said, the difference between that and an interpreter. And I actually took the test when I was in fellowship a couple of years ago. I just barely didn't pass, but I actually haven't been motivated to take it again because even before trying to take that test, had been asked several times to interpret for other people, knowing that that's not appropriate, and puts you in a very awkward situation to say no to someone when they're asking for your help. And then on the flip side, I've had many experiences since being here at Loma Linda where people have offered their help as a non-certified bilingual staff member, and it's also awkward to tell them thank you, but no thank you, and to explain why. And most commonly I'm met with kind of this feeling of being either defensive or offended by me saying no. And I try to explain, but it's a very complicated thing. So I think I guess I'm trying to champion this awareness at this very large NICU of what's appropriate and not appropriate in terms of interpreter services. And it's difficult when people who have been helping, even though they're not qualified, they've been helping for so long, it's difficult to address that culture change, especially if it's just one person attempting it. So. And I've had the personal experience too of using a social worker who, she was excellent. I loved working with her. She was, Spanish was her first language, but she wouldn't interpret it exactly what I was saying. The general message was getting across, but she would oftentimes respond herself to what the family was saying before I had a chance to respond. She'd kind of add her 2 cents in, and sometimes it wasn't actually 100% accurate. She wasn't, because I know Spanish, so I knew what she was saying. It wasn't what I was saying. So a lot of things.
Thank you.
I want to say thank you for even taking the test, because I have heard that it is a hard test and some people don't even want to try to even take it. So kudos for you for even going to take the test. I understand everything that you're saying. I hear it all the time. I like all of your hospitals. I don't know if all of you know that, but I know about all of your facilities. So if there's anything that, I can do on my end to help you guys, do any of this better, any of the toolkit better at your facility, please don't, feel ashamed or like you're stressing me out or anything. Please ask me questions. Please, invite me to a meeting. This is very important to me. And it sounds like all of you so far know the difference of, what's a qualified bilingual staff and an interpreter, as well as you guys having these already important roles at your facilities. And I really don't think the iPad is going to cut it. And I really don't think that you guys should be pulled all in each and every direction. I do think that we do need to have, like I said, financial compensation to those that can do it. Because like you said, I think it was you, Emily, you said you had worked with a social worker before and other, people. And there may be someone who's in that team who can be a qualified bilingual staff member or interpreter who's working, let's say they just started and they're working in admin and they're just coming in, so they're at the lowest level, but they can actually be an interpreter. So, giving that opportunity to everyone is very huge. And thank you for all your input, Emily. I just wanted to say that.
Okay, let's move on to talking about phone and video interpreters. This is, as you can see, this is saying they're not the gold standard of care since they can't access patient chart information or provide continuity of care, but they do give you a quick answer when you really need it. As long as they're empowered to be communication partners and they're provided with the critical patient information, such as the context of the situation, the location, and the communication goal. I'm assuming all of the hospitals have these available to you. Is there any discussion that we should have around this, or do we, or should we move on to the next question? I'm going to leave it open for a second for comments.
I would love to know, how do you guys like the phone and video interpreters? How do you like them at your facility?
Thank you. And Kim has raised her hand. So Kim, do you want to go ahead? And then I think Julianne maybe next.
Sure. So we use the phone interpreters a lot when we can get an appropriate interpreter for the situation. But as I'm sure many people have run into, it's the same kind of conversation. The person, maybe Julianne was speaking before, but anyway, that you have a long explanation of what's happening, and then the interpreter on the line is supposed to repeat exactly what you're saying. And yet, what you just took 10 minutes to say suddenly came out in 2 sentences, right? And so the really hard part is if it's me using an interpreter into some other language, I can't, I don't have enough knowledge base to know exactly what they're telling them, right? So that's really tough. So you're kind of, you're left in a spot, right? You just don't know what's coming across, right? And the second part is we have families who refuse to use the lines, right? They refuse to use some faceless person on the phone, right? And so that puts us in a whole nother bucket, because now if we don't have somebody who can speak to them in person, then we have been in situations, especially with Mesteco, that we have had to use a family member, and nobody's saying that we like it. I'm just going to be, but in the moment when you have no other tool to pull from, it's what happens. And that's even a worse feeling because you really don't know what's happening at all. So, yeah.
Thank you. Thank you for that comment. That does sound really difficult and really highlights some of the issues, I think, with the phone interpreters. Yes, over to Natividad, please.
This is Reverend Lawrence. I was just going to comment that whether I like it or not was really irrelevant. What I noticed is that the patients themselves didn't like it. The patients didn't like it and the families didn't like it. So, and then with the quality of the interpretation, it doesn't even compare when the interpreter's in the room. There's no comparison. It just a lot of question asking and a lot of questions, and could you repeat that again and such. So it just breaks up the flow of the conversation. and patients become disinterested after a while, so. Whether I like it or not is irrelevant. I just know that our families don't care for it much.
Beautiful point that you brought up there, and thank you for bringing that up.
And
I didn't realize that there was a lot of questions and it's breaking down your flow of the conversation. So great point. Thank you for bringing that up.
And I just wanted to add one component to that. It is a multifaceted situation because there are cases and there are cases. So I have kind of learned through my experience, palliative care, conversations that are lengthy and more critical, that's not the most practical because of the nature of the conversation. But there are other locations where video units and phone units do excel and might be better. So the way that I kind of illustrate it is sort of like when using an interpreter, both in video or in person, it's sort of, and they're more than this, but it's sort of like a tool. If you don't know how to use the tool, it's not necessarily the tool that has the defect, but perhaps the user. And so sometimes we have to just assess, are we experienced or have we had the training on how to utilize an interpreter? Because each of these have a level of niche. So, and again, bear in mind that if we could afford or have the bandwidth for one interpreter per doctor, per nurse, per case manager, that would probably be the case, but we just don't have that capability. That's why video, that's why phone interpreters exist. But we have to also have people that are at the forefront evaluating these services to make sure that they're up to par to how they're being serviced, right? So it's not just a free-for-all, but are we getting the best interpreters? Oh, this one needs more training. Let's get back to them and try to give them that help, you know? So it's multifaceted.
Thank you. Emily.
So I 100% agree with the fact that it's, I think it's more so knowing how to use the tool, as just mentioned, rather than the tool itself, to some degree. I think my biggest issue with the either phone or video interpreters has sometimes been like internet connection cutting out and disrupting the conversation. But the previous hospital I worked at, we actually didn't have in-house interpreters. And so we solely had to rely on video or phone interpreters. And so I've had a lot of experience with the iPads. And while I would always prefer to have an in-person interpreter, I've had some very successful interactions. But I think, you know, little things like knowing where to position the iPad so that the family will still look at you, speaking clearly and loud enough and slowly enough and in you know, short phrases, which we do anyways with in-person interpreters, but even more so when you have to go through a phone or through the iPad, I think is important. But I've had good experiences and negative experiences with both phone, video, and in-person interpreters. And so I know a lot of people feel strongly that the video or phone interpreters are not, you know, not as good, which I agree with, but like I said, I've had, sometimes you don't have a choice, and I've had good experiences. I have to call families from home after their baby dies and have difficult conversations about autopsy results over the phone. And I use phone interpreters, and it's worked very well. So I think that there's just positive and negatives to all of them.
Right. I think your point is well taken, you know, and stressing the point that it's knowing the best way to use the tool. And in addition, it isn't necessarily, is this better than an in-person interpreter? It's, you know, is this the next best thing? You know, if you can't have an in-person interpreter, this is sort of the next place that you go. Thank you. Thank you for that. Lindsay.
Hey, I'm a neonatal CNS in the NICU, and I work a lot with the families who are carrying high-risk fetuses and setting up consults for them so that they can anticipate kind of what to expect when they are admitted to the NICU. One thing that, echoing what Emily said, I've had difficulty with is kind of the logistics and the technology working for these families. When I call them to set up the appointment, it takes a good amount of time to get the right interpreter on the phone, to explain the situation and then to connect with that family. And then usually that's kind of my one shot to talk to them and explain, this is why I'm calling. These are the dates I have available. I'm confirming the date, and then I will see you on Zoom.
Mm-hmm.
And then I'm realizing they don't have a way to get back in touch with me using an interpreter after I set up that consult. So they don't have my phone number. Maybe they can call the hospital and figure out who was this NICU person that called them, but probably it's not enough time and interaction for them to process who I am and why I'm calling and what questions they might have. And then just logistically with Zoom interpreters, when we finally do have these consults, I've had issues where for some reason the call just drops off after 2 minutes and I have to keep reconnecting. And it's a different interpreter every time. And it takes a good amount of time to explain again, this is the situation, this is the family.
Mhm.
I have you for another 30 seconds before you cut out. So I definitely feel like a lot of the communication is one way. It's from me to them on my time, which doesn't always feel just. And I can't find it yet, but I'm sure that there is a way for them to be able to communicate back to me. But that again requires them to navigate our hospital's website, for them to be like technology proficient, to either email me or call me, to have those resources available, which again is just another layer to it.
Great, thank you.
Thank you so much.
I'm going to go back to Lindsay, but I do want to make sure that we get keep moving and get through these others, but please go ahead.
Oh no, that was it from me.
Oh, okay,
Sorry,
great.
I tried to lower my hand.
Thank you. I'm always sort of dithering between, I want to give people as much time as possible, but I want to make sure we do go through everything if we can. So the next point is being cognizant of body language. And I think this is, we all can just sort of sense intuitively that this is huge, and just being careful not to use body language around the family that they're a burden, or that they're taking more time, or that they they're taking up too much of your time that should be spent doing other things, or that communicating with them is not the main work of your day. Are there thoughts around this? I mean, this seems like a really a strong point that I think all of you are probably really in touch with. Natividad.
Yes, one body language that I've noticed, whether in the NICU or the ED or wherever I may be, when a doc starts looking at his watch, or they start looking at their
Yes.
phone maybe prematurely or something,
Yep.
that just breaks that, gives a message to the people they're communicating to, that they perhaps would rather be somewhere else.
Yes, that's very hard. Yeah. That's an automatic signal, isn't it?
It is.
When you see somebody do that. Thank you.
Thank you for sharing that.
Okay, this next one is also really important. I mean, they're all really important, but this one is moving on also into things that CPQCC is really thinking about doing and planning to do larger projects on going forward, which is completing a family assessment on the cultural and the social contexts that may impact families, in order to determine the resources that the family prioritizes. So what are the resources that they most need, and what resources are available in the community that you can help, or that your hospital can help put them in touch with. I think this is more and more part of the picture for us today. And as it points out here, receiving hotel vouchers may be more important for them than WIC benefits. It all depends on what the family's need really is. And that obviously impacts their ability to really comfortably and not wholeheartedly, because obviously they're going to be wholehearted, but to be able to be in the NICU and be a full part of their baby's care team. Again, I'd just like to ask, is this, would you raise your hand if this is something that your hospital routinely does with families?
This is something our unit routinely does, but for all patients. I know it's even more so important for families who speak a different language, but I think the goal is to do this for all patients, and there's at least some sort of assessment done.
Absolutely. Absolutely.
I believe that if we can fix, and I always say this, if we could fix the worst problems for certain groups, then hopefully at the end of the day, it would all equal out to equality because everyone will get the same treatment. So thank you, Emily, for saying that. It's equal. Everybody gets it.
That's right. Okay, and then the last change idea that we wanted to bring up was building community for families with a non-English language of preference, holding meetings with former NICU parents who have a non-English language of preference, and with the NICU staff to discuss the experience between the patient and family and the staff, and the care that was received, including what went well and what are some ideas that could be improved upon. Family Advisory Council information is available in this site. I would also like to say that CPQCC has instituted our first Family Advisory Council statewide. And they're very, very interested in this area and in providing educational materials for families that are coming into the NICU. One of you was saying earlier, talking to families that are starting to hear, prenatally starting to hear that their baby is probably going to spend time in the NICU. And, a lot of families have no idea what that is. I wouldn't have had any idea what that was or what to expect. And so providing things like that. So family-centered care committees include staff and families that can plan interventions and plan quality improvement projects that can develop data points so they can say, okay, here's where we were, and we tried these ideas and we saw an improvement in care, and integrate families and their viewpoints and their voices into how care is provided in the NICU. So do your sites have communication, sort of formal communication set up in this way with families with NELP after they leave the NICU? Is that something that's available? Yes, Natividad, thank you.
So one of the components, and we're just discussing that, is that we have to bear in mind, although, so in this cultures that would fall under the NEL and the NELP, right, NELP, they're working families and working, they're all working really. I mean, from mom to brothers to sisters to younger siblings. And so taking in context the time availability that they have to dedicate to this would be a big component, right? Because sometimes with the best intentions, we create these very comprehensive programs or meetings to meet with them, to give them all that information at around maybe 2 o'clock in the afternoon, and they're all working. They're working at that time. And so sometimes we have to pick odd hours, what would be convenient for them to maximize the attention, right? So that's one component of many other ones. Another one that we see in our community, particularly for Indigenous communities, is that they're very reluctant to approach big institutions and big institution projects because they don't know how to navigate those kind of ideas or those places. So what we're seeing, and I think palliative care, our team palliative care is trying to bring spotlight to us as interpreters, is that they really do need more than just an interpreter. It's almost like they need a community liaison of sorts, or some sort of an ambassador that will be there to not just interpret, but also kind of navigate through a lot of these things. And so that's really not so much the conflict we're having, but it's the coming to these two worlds. Palliative care team, great about, can we help families and part-time interpreters? Can we help them understand? And sometimes we don't have the bandwidth, but that's really what you're kind of seeing, a shift in this culture, in this work culture, really.
So go ahead, Rebecca.
Oh, thank you. I was just going to say that is a really great point. Thank you. Is accommodating their working hours, and also for family advisory councils. We were advised as we were starting ours that one of the most important things is to be able to pay people for their time, because as you point out, not everybody, most people work. A lot of people don't have, free time that they can just volunteer, for a big hospital or something. And so being able to say, hey, we really value your expertise, and we would like to pay you for your time if you can provide it to us, is also another way of showing sincerity, I think, really, to the families. So thank you. Please go ahead, Ashley.
And I'll add in, I'm not sure if you know a little bit about my story. The reason why I got into this was because I'm a 3-time preemie mom. So I originally wanted to be an OBGYN, had my 3 preemies, and the whole thing changed around. So I understand what you mean when you mean community liaison. And I do believe that the world is slowly changing that way. With Globe Preemies, unfortunately, we only stick with Black families. But I am hoping that there will be an organization similar to mine. We stay with families from the NICU all the way until the child's 18. So we are that community liaison that navigates with them through the healthcare and the education system, as well as a workforce for the parents. And I hope that every organization, or multiple organizations, will start doing something similar so that all of these families feel like they have someone to go to. I'm a true advocate on speaking that you guys do a million things and you do a million things perfect. You guys do need your help. If you do have a favorite community organization, if they don't have something like that in place, maybe that's a conversation that you guys can start. And that way it's not such a burden on your facility, and the community organization may love to take that on and help, partner together on that and be a better fit for your families.
Ashley, the work you do is just amazing. It's just wonderful.
Thank you.
So honored to be here. So I wanted to move on to our discussion questions, and with your kind permission, everybody, I'd kind of like to skip over the first question. We can always come back to that, because I think I assume everyone does provide interpreters, but Ashley and I were talking about this just before the meeting, and we were, wondering, do your units have a process for identifying NELP families? Is it applied to every family, or is it kind of left up to the people who are interacting with them directly to discover what their language of preference is, or make assumptions? We'd be very interested in hearing how that works. Yes, Emily, thank you.
So I'm actually not familiar with what our exact process is here at Loma Linda, but actually one of the places that Lindsay works at is where I was before. And when I had asked the nurses in the NICU, how do we assess families for their language preference, I was told that the admitting nurse would address that question. They have a couple of intake questions that they ask all families, but the wording of the question wasn't standardized. And I think there's a Joint Commission phrase that's recommended to use. And I left before getting the chance to maybe implement that as the standard phrasing. I'm hoping to do that here after I learn a little bit better about the intake process. I think a lot of it is, moms, a lot of our babies are inborn. And so we have mother's information in the medical record. And so if it says that she prefers a different language, that gets carried over to the baby in some way. But for the babies that are transferred out, or, I don't know what the OB system is in terms of identifying those who prefer a different language. There's obviously the possibility that certain families could get missed. We have a lot of families who speak some English, speak some Spanish. They primarily speak Spanish at home, but, quote unquote, know enough English that English is good enough. And so I think sometimes they, even if it says Spanish in their chart, we don't use it. So hoping to learn a little bit more about our process here.
Great. Thank you so much for that. Yes, Natividad, thank you.
I did have a question in regards to the acronym here, and actually the great question that we have a process for identifying it, in the interpreting world, as professional interpreters, we get trained with another acronym that's, I think it's similar, but maybe a different motivation, which is LEPs. And when we say that, we're talking about limited English proficient individuals, right? So I guess my question, and I'm sorry, maybe we've already talked about this, what would be the difference, in your opinion, when it comes to non-English language preferred families and LEP for limited English proficient? The only one that I could probably say at my profession is that one of them is we take it upon ourselves to identify them for the purpose of linguistics, where this one's a little bit more comprehensive to the needs that they may need, but because we do have a process for identifying LEP, the question is not so much is it enough? Really, it's probably where we would like to go, but I'm just curious what your opinions on that would be.
I think that's a great question. And Caroline Tony Nolan was the person sort of was Ashley's partner in working on this toolkit, and I think they worked through, what the preferred way to identify these families is. And LEP was what I had most recently heard, limited English proficiency, but I think NELP was what took it from being kind of a judgment of the family and their abilities and turned it into what is their preference. Because they may be very fluent in several languages, but they do have a language, they do have a language that they prefer. And, they may be fluent in English, but they may be more comfortable in another language. And so that's their preference. So I think that's how I think of it.
Said it right.
Okay, perfect. Great. I was going to say, but I'd like to turn it over to somebody who can say it better. But yeah, so I think it's just, I know it can be annoying, but I also think it's kind of comforting to see language and evolving in this way, in the way that we're always trying to find the best way to speak about, how does a group want to be spoken about? How do we want to identify ourselves to other people? How do they want to identify themselves to us? So I think that's where this has come from. Thank you for the question. Kim, please go ahead.
So I don't know that we have a formal way of identifying other than just, from shift to shift, letting them know that, this family would need a translator, non-English speaking. So it's a bit informal and probably could be standardized. But I also wanted to mention that as part of our new hire orientation, I do the patient satisfaction presentation. And one of the things I talk about is explaining in a way you can understand for the patient, which then means that we all need to identify the language of preference for the patient. And then using an example of, I might speak English, Spanish, and Italian, but I might understand better in Spanish, if you will, right? So I take a little time just to try to drive that home to everybody who comes through new orientation, new hire orientation, so that we're trying to set the expectation that this is how we would do it across the hospital, not just in the bedside world.
Great point. Thank you. So I think an interesting question that came up, and I'm just going to throw this out there as a possibility to talk about. This was brought up at our Family Advisory Council meeting as a kind of an icebreaker question, just to, not that there's a right answer, but just to kind of think about what are the different ways to handle this. If you had a family come in and they spoke two languages, let's say they spoke both English and Spanish, and you asked them and they said, go ahead and communicate with us in English, but the feeling of the staff was maybe they're not, getting all of the information that we want them to get in English. How do you handle that? You know, because obviously you want to be sensitive to their, the way, you know, the way they, you know, how they put forth their needs, and how they, but you also want to be sure they're getting all the information. What, you know, what would be some of the ways you would go about handling that?
And a great example of that, Rebecca, that came up a lot, and I'm hoping that you guys have answers to it, because I would love to hear it. When we were making the toolkit, we came across a lot of the physicians and social workers saying, like, maybe dad speaks Spanish, mom speak English, or something like that. And when they're both in the NICU, how do you make them both feel like they're heard, and that one is not more important than the other? So thank you for bringing that up, Rebecca.
Good point. Yes, Emily, thank you.
So interestingly, I've actually been asked this question several times in just the last week. And what I have found useful when I'm in these situations is, you know, taking the decision off of the family, and kind of trying to emphasize how it's actually, I'm legally obligated to use an interpreter. And this is what we have to standardly do for all of these interactions. I think in my experience, when I phrase it that way, many families who initially said, you know, either English is okay, or, you know, please use my family member to interpret, they usually understand where I'm coming from. There's been a couple of times, and anecdotally I've heard from other people, where families felt very strongly against using an interpreter, either because of a past negative experience, or because I think, you know, discomfort with having a third party involved in such an intimate conversation. But in those, I think that's a trickier situation. And I think I would never want to make a family uncomfortable or disrupt any rapport I've built with them by forcing an interpreter on them. I think that if nothing else, I would try to have an interpreter present, even if a family member is primarily interpreting, so that you know, there's another party there to kind of notify me of any disconnect between the information I'm saying and what's being interpreted. But that's been my recommendation to other staff members here who have asked me that question.
Thank you. I'm making notes about that. That's very interesting. Thank you. That's very helpful. Natividad.
So one of the things that, and hearing everything that's going on, I think, and to take something that I've learned from the palliative care just by observation, is that when it comes to that question, it's a pretty big question, because if I hear it correctly, part of it is, well, we want to offer the interpreter, but how do we know if we're pushing it too much or not? And what I can say is that it's a process, and the way that I kind of would illustrate it here is, in the case of, like, for example, DNRs and do not intubate, it's not a yes or no question. It's a question that takes some process. Sometimes you have to take several conversations to lead them or help them find their way to being able to accept or decline a decision. And the same thing could be true about language. They may start with the idea of, I don't need an interpreter, because that's how they've lived most of their lives. Most of the time they enter into these institutions, they don't have interpreters. I mean, we're talking about clinical, right? But what about when they go to the post office, when they go to other community services that aren't mandated to have interpreters, right? So again, humans are kind of like water. We follow the path of least resistance. So whatever's easier, that's kind of what we're going to be doing, right? And so for them, it may be easy to say, no, that's okay, I'll do it in English. Halfway through the conversation, they realize, you know what, I'm not understanding. But on the other side of it, clinicians, they have the responsibility of making sure that they understand when they make these decisions. So there's the two worlds of comfort level. Yes, it's up to the patients, but it's also up to the physicians and the providers. Do I feel comfortable giving this diagnosis or this kind of procedure or request without an interpreter? So we have to kind of explore really this more, it's a complicated question. There is such a thing as personal autonomy, right? The patient's autonomy. We want them to have the autonomy to decide for themselves based on the information that they have. But here's the caveat to that. Is it an informed decision?
Mhm.
That's the only way that autonomy can truly exist, is that if it's an informed decision. If they don't have the informed decision, then they're really not taking the decision with full autonomy. So again, this is why you need key personnel, physicians that are very proactive to this, and providers that understand that this is something that is a case by case on some occasions. Sometimes you might have the luxury of yes or no questions, and they're pretty easy, but it's a process. So we do have to take a lot of things into consideration.
Thank you so much.
That's a great way to think about it. I love that idea that it's not just a yes or no decision. It's a process to come to that, to how you get to the right decision for them. That's wonderful. I would just say we're right at time. We didn't have time to talk about whether support groups or community building events. So I would just throw that out there as something that's an interesting idea for you all, perhaps to think about if that's something that your sites don't do. I can't thank you enough for being here with us today. I really value the chance to hear from you all who are on the front lines and doing such difficult work with so much love and care and expertise and wisdom. And it's just wonderful. And we at CPQCC really believe in these providing spaces where you can all come together in a community of learning, because it's not that we know all the right answers. It's that we hope we can provide space for you to come together and say, well, here's how we've solved this problem. Oh, that's interesting. We've also tried this other thing, and you're really teaching each other. And that is so valuable. So thank you. We really appreciate it. And I also just want to thank again, Ashley Randolph, who does such wonderful work for the babies of California and is so gracious as to share her time and expertise with CPQCC. If you have any questions or any follow-up thoughts, you can always email this info@cpqcc.org. And that goes to one of our team members who generally brings it right to me. So it will get to me. If you have any follow-up questions or any thoughts, I would be very happy to chat or connect you with my colleagues who know much more than I do in this area. Ashley, did you have any final words?
I just want to say thank you from a preemie parent, and all of your work does not go unnoticed. And thank you all so much for being here today. If I had to say it, all of you are NELP champions, and I thank you all for helping all of your families.
Thank you.
Thank you all. Thank you for being here. We hope to see you again soon.